Welcome to StudyNeuro, where we provide high-yield neuroscience education and clinical pearls. In today's presentation, we will explore ankylosing spondylitis, a chronic inflammatory condition that mainly affects the spine and sacroiliac joints. We will examine how the disease presents, how it is diagnosed, and how modern treatment can improve long-term outcomes. We will begin with an overview of the disease and its epidemiology, before exploring the genetic factors and biological processes that contribute to its development. Next, we will discuss the major clinical features, diagnostic approach, and the role of imaging in assessing disease activity and structural damage. We will then review current management strategies, including medical treatment and surgical considerations, before examining important complications and the overall prognosis of the disease. By the end of this presentation, you should have a clearer understanding of ankylosing spondylitis, from its underlying mechanisms to diagnosis, treatment, and long-term care. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Like, comment, share, and subscribe to stay connected with our latest educational content. Let's begin.
Ankylosing spondylitis is a chronic inflammatory disease caused by abnormal immune activity. It mainly affects the axial skeleton, especially the joints between the spine and pelvis, the spine itself, and the entheses, which are the points where tendons and ligaments attach to bone. It is the most common and classic form of axialspondyloarthritis. The disease can also affect organs outside the musculoskeletal system. It may gradually cause structural damage and stiffening of the spine, leading to deformity and disability. This is a major cause of chronic inflammatory back pain in young adults. The impacts can be significant, affecting daily activities, work productivity, and overall quality of life. It is a serious long-term condition.
Ankylosing spondylitis occurs worldwide, but its frequency varies considerably between populations. Globally, estimates suggest that about 0.1 to 1.4% of people are affected, while European studies generally report a prevalence of around 0.3 to 0.5%. The incidence also varies widely, partly because the disease is more common in populations where the HLA-B27 genetic marker is frequent. The disease usually begins in early adulthood, with symptoms most often appearing between 20 and 40 years of age, and a mean onset of about 26 years. Most patients develop symptoms before the age of 30. Early onset is typical. Ankylosing spondylitis also shows a clear male predominance, affecting men about 2 to 3 times as often as women. Overall, these patterns highlight an important point. This is primarily a disease of young adults, with both genetic background and population factors influencing its distribution. The exact cause of ankylosing spondylitis is not fully understood. It develops through an interaction between a person's genetic susceptibility and environmental influences. Genetics matter, but they do not act alone.
The strongest known genetic association is HLA-B27, although only a proportion of people who carry this marker develop the disease. Risk is also higher in those with a family history, particularly in young men, while factors such as changes in gut bacteria, repeated mechanical stress at the enthesis, and previous gastrointestinal or genitourinary infections may contribute to disease development. These factors can interact in complex ways. Other genes also play a role. ERAP1 and IL-23R are important examples, next to many other non-HLA susceptibility genes that influence immune responses and help determine an individual's risk of developing ankylosing spondylitis. Genetics and environment work together. HLA-B27 is a protein found on the surface of cells and belongs to a group called Class I major histocompatibility complex molecules. Its main role is to help the immune system recognize protein fragments and present them to immune cells. The association with ankylosing spondylitis is strong. HLA-B27 is found in roughly 80 to 95% of affected patients, depending on the population studied,
and it may account for about 1/3 of the genetic contribution to disease susceptibility. But the relationship is more complex than it first appears. HLA-B27 increases risk, but it does not guarantee disease. Most people who carry HLA-B27 never develop ankylosing spondylitis, while some patients with the disease do not carry the marker at all. Other genetic and environmental factors are clearly involved. HLA-B27 is important, but it is not the whole story.
The distribution of HLA-B27 across the world helps explain why ankylosing spondylitis is more common in some populations than others. In general, populations with a higher frequency of HLA-B27 also tend to have a higher prevalence of the disease. For example, HLA-B27 occurs in about 24% of people in northern Scandinavia, compared with around 8% in white and Chinese populations. The frequency is lower in many African populations, at about 4%, and is approximately 1% in Japanese populations. These differences are important. They show a clear relationship between genetic background and disease prevalence, although HLA-B27 alone does not determine who will develop ankylosing spondylitis.
Genetic susceptibility alone is not enough to explain the development of ankylosing spondylitis. Environmental factors may help trigger the disease or increase immune activity in people who are already genetically predisposed. The gut may be particularly important. Changes in the normal balance of intestinal bacteria, known as gut dysbiosis, have been linked to inflammation, while infections involving the gastrointestinal or genitourinary tract may also act as potential triggers. Mechanical stress at the entheses, where tendons and ligaments attach to bone, may further contribute to local inflammation. Several organisms have been associated with these processes, including Chlamydia trachomatans, Salmonella, Shigella, Yersinia, and Campylobacter. The immune system may then become persistently activated. In genetically susceptible individuals, these environmental influences could initiate or amplify inflammation, helping drive the development and progression of ankylosing spondylitis. The pathogenesis of ankylosing spondylitis begins when genetic susceptibility interacts with environmental triggers, leading to activation of both innate and adaptive immune responses in susceptible individuals. This immune activity promotes chronic inflammation, particularly at the entheses and sacroiliac joints. Over time, inflammation can cause bone erosion and inflammation within the bone, followed by abnormal new bone formation that produces syndesmophytes and eventually spinal ankylosis. The process is not simply inflammation followed by bone formation. Both occur together. Persistent disease activity can therefore drive progressive structural damage, gradually changing the normal architecture and function of the spine. The interleukin-23 and interleukin-17 pathway is a central part of the immune response involved in ankylosing spondylitis. It begins when antigen presentation activates the immune system, leading to production of interleukin-23, which promotes the development and activity of T helper 17 cells. These cells then produce interleukin-17A and interleukin-17F, which stimulates other inflammatory signals, including tumor necrosis factor alpha, interleukin-6, and interleukin-1 beta. This creates sustained inflammation, particularly around the entheses. The process can continue for years. Persistent activation of this pathway contributes to chronic inflammation and may also influence abnormal bone formation. As a result, ongoing immune activity can drive both tissue damage and the structural changes characteristic of ankylosing spondylitis. Several immune cells contribute to the inflammatory process in ankylosing spondylitis. These include CD4 positive T lymphocytes, CD8 positive T lymphocytes, and macrophages, which interact to sustain inflammation in affected tissues.
The inflammation is not limited to one location. It commonly involves the sacroiliac joints and entheses, while other areas of the spine, including the vertebral corners, facet joints, and intervertebral discs, may also be affected. The pattern can vary between patients. Inflammation causes progressive structural damage. Over time, repeated inflammatory activity can alter normal bone and joint architecture, contributing to stiffness, reduced spinal mobility, and eventual ankylosis. Pathological bone formation in ankylosing spondylitis begins with inflammation at the entheses, followed by inflammation within the bone and areas of bone erosion. During repair, fibrocartilage develops and is gradually replaced by new bone through a process called endochondral ossification. This process drives syndesmophyte formation. Over time, these bony bridges can extend between adjacent vertebrae and eventually lead to spinal fusion. The spine gradually becomes rigid. Several molecular pathways help regulate this abnormal bone formation, including bone morphogenetic proteins, transforming growth factor beta, and the WNT signaling pathway. These signals influence mesenchymal stem cells and promote osteoblast activity, encouraging new bone formation that ultimately contributes to syndesmophyte development and ankylosis. Inflammation in ankylosing spondylitis can increase the activity of osteoclasts, the cells responsible for breaking down bone. This leads to greater bone resorption and ongoing remodeling of the vertebrae, which may contribute to reduced bone strength and osteoporosis, even while abnormal new bone is forming. The cyclooxygenase pathway also has an important role. Cyclooxygenase 2 helps produce prostaglandin E2, a signaling molecule that influences inflammation and bone metabolism. Through these effects, it can affect osteoclast activity, osteoblast function, and the process of bone healing. The result is a complex balance between bone loss and new bone formation. The natural history of ankylosing spondylitis is one of gradual progression. Without adequate treatment, ongoing inflammation can lead to irreversible structural changes and loss of normal spinal movement. The disease often begins with inflammation around the sacroiliac joints and may then extend through the lumbar and thoracic spine, eventually causing fusion in the cervical region. As the spine becomes increasingly rigid, some patients develop a fixed forward curvature known as kyphotic deformity. This can significantly affect function. Approximately half of patients may develop clinically important sagittal deformity within 10 years, which can progressively impair posture, mobility, balance, and daily activities. Early recognition matters greatly.
The clinical manifestations of ankylosing spondylitis mainly involve the spine, but the disease can also affect peripheral joints and the areas where tendons and ligaments attach to bone. Axial symptoms often begin with inflammatory back pain and morning stiffness, followed by gradually increasing spinal rigidity. As the disease progresses, patients may develop reduced chest expansion, loss of the normal lumbar curve, and an exaggerated forward curvature of the thoracic spine, while advanced cervical involvement can lead to significant deformity. These changes can severely limit mobility. Peripheral joint involvement commonly affects the hips, shoulders, or knees, while enthesitis causes inflammation where tendons or ligaments attach to bone. Dactylitis, which causes diffuse swelling of an entire digit, is less common. Hip involvement is especially important because it occurs in approximately 1/3 of patients and is linked to poorer functional outcomes. It matters clinically. Ankylosing spondylitis can affect organs beyond the joints and spine. The most common extra-articular manifestation is acute anterior uveitis, an inflammation of the front part of the eye that can cause significant pain and visual symptoms. Cardiovascular involvement may affect the aortic root and heart valves, while conduction abnormalities can also occur. Pulmonary disease is less common, but may include restrictive changes and rarely fibrosis involving the upper lung zones. The disease may also occur alongside inflammatory bowel disease, while long-standing inflammation can contribute to renal complications, such as secondary amyloidosis and chronic kidney disease. These systemic manifestations matter. They can influence both perioperative assessment and the patient's long-term prognosis. Plain radiography is commonly used to assess the sacroiliac joints in ankylosing spondylitis. The classic finding is bilateral sacroiliitis, which is often relatively symmetrical. As the disease progresses, inflammation causes changes beneath the joint surface, followed by erosion and reactive sclerosis. The joint space may initially appear widened, then gradually becomes narrower, and in advanced disease, the joint can become completely fused. The changes become more obvious over time. Plain radiography is widely available, relatively inexpensive, and quick to perform, making it useful for assessing spinal alignment and established structural damage. However, it has limited ability to detect early inflammation and provides poor visualization of soft tissues, while also exposing the patient to ionizing radiation. Another important finding is the syndesmophyte. These are thin, vertically oriented bony bridges that develop along the margins of adjacent vertebral bodies. Over time, they can connect neighboring vertebrae and produce the classic appearance known as a bamboo spine. A bamboo spine represents advanced structural disease. It causes loss of spinal flexibility and increases the risk of vertebral fractures, while progressive spinal rigidity can also contribute to sagittal deformities. Computed tomography provides excellent detail of bone and is especially useful when plain radiographs are unclear or when more precise assessment of structural damage is needed. At the sacroiliac joints, computed tomography can show erosions and irregularity of the joint surface, along with sclerosis and progressive narrowing of the joint space. In advanced disease, partial or complete ankylosis may be clearly demonstrated. In the spine, computed tomography can reveal characteristic changes, such as vertebral body squaring and Romanus lesions, while also showing syndesmophytes and ankylosis of the facet joints. These findings may eventually combine to produce the classic bamboo spine appearance. Computed tomography can also demonstrate ossification of the anterior longitudinal ligament, the posterior longitudinal ligament, and other spinal ligaments. Ankylosis of the joints connecting the ribs to the spine may also be identified. These findings help define the extent of advanced structural disease. Early spinal changes in ankylosing spondylitis can appear before the more advanced features of spinal fusion. One important finding is the Romanus lesion, which represents an erosion at the corner of a vertebral body caused by inflammatory enthesitis. These lesions reflect active inflammation at the attachment sites around the vertebral end plates. Another early change is vertebral squaring. This occurs when chronic inflammation and bone remodeling reduce the normal concavity along the front of the vertebral body. These changes can develop before syndesmophytes become visible. They matter clinically. An Anderson lesion, also known as a discovertebral lesion, is different. It results from mechanical stress and repeated microtrauma, particularly in a spine that has become rigid, causing inflammation and structural damage involving the vertebral end plate and the adjacent intervertebral disc. Magnetic resonance imaging is particularly valuable in ankylosing spondylitis because it can detect active inflammation before permanent structural changes become visible on plain radiographs. It also avoids ionizing radiation and provides excellent soft tissue detail, while allowing the spine and other affected areas to be assessed in multiple planes. T1-weighted images are mainly useful for identifying structural changes, including erosions and established ankylosis. In contrast, Short tau inversion recovery and fat-suppressed T2-weighted sequences highlight active inflammation by showing bone marrow edema. They are also useful for detecting osteitis and enthesitis. These sequences are essential. MRI can demonstrate inflammatory lesions at the corners of vertebral bodies, together with bone marrow edema and osteitis. As the disease progresses, it may also show structural damage, such as erosions, syndesmophytes, and ankylosis. Clinically, MRI is important for detecting axial disease when plain radiographs are still normal. MRI findings can contribute to the assessment of Spondyloarthritis International Society criteria, while repeated imaging may help assess inflammatory activity and response to treatment. It can also provide information about the risk of future structural progression.
The diagnosis of ankylosing spondylitis relies on bringing several pieces of information together. The process begins with the clinical history and physical examination, then uses laboratory tests and imaging to support the diagnosis and assess the extent of disease. HLA-B27 testing can help identify genetic susceptibility, while C-reactive protein and erythrocyte sedimentation rate provide information about systemic inflammation. These tests are supportive, not diagnostic on their own. Imaging is essential. Plain radiographs help identify established structural changes, while magnetic resonance imaging is particularly useful when early or active inflammation is suspected. Computed tomography provides more detailed assessment of bone abnormalities, especially when structural damage needs to be defined clearly. No single test confirms the diagnosis. The modified New York criteria include 3 clinical features that reflect inflammatory spinal disease. The first is chronic low back pain and stiffness, lasting at least 3 months, typically improving with exercise rather than rest. The second is reduced movement of the lumbar spine, assessed in both forward and backward movement and side-to-side movement. The third is reduced chest expansion compared with what would normally be expected for the patient's age and sex. These findings indicate reduced spinal mobility. They are clinically important. The radiographic criterion focuses on sacroiliitis seen on plain radiographs. The required finding is either bilateral sacroiliitis of at least grade 2 or unilateral sacroiliitis of grade 3 or 4. Radiographic sacroiliitis is the key imaging feature. To classify a patient as having ankylosing spondylitis, using the modified New York criteria, radiographic sacroiliitis must be present alongside at least one of the 3 clinical criteria. The modified New York criteria classify ankylosing spondylitis. The modified New York criteria classify ankylosing spondylitis based on the combination of clinical features and radiographic evidence of sacroiliitis. A definite diagnosis requires radiographic sacroiliitis together with at least one clinical criterion, meaning that imaging evidence must be supported by relevant symptoms or physical findings. There is also a category called probable ankylosing spondylitis. This was used when patients had all 3 clinical criteria without radiographic sacroiliitis, or when radiographic sacroiliitis was present without the required clinical features. This category is important historically. However, it is less commonly used in current clinical practice, where newer classification systems can identify patients with earlier or non-radiographic axial disease. The differential diagnosis of ankylosing spondylitis includes degenerative spondylosis and diffuse idiopathic skeletal hyperostosis, which can produce overlapping spinal changes but have important differences on imaging. In ankylosing spondylitis, the syndesmophytes are typically thin and marginal, with a more vertical orientation, while degenerative spondylosis produces broader, more horizontal osteophytes. Diffuse idiopathic skeletal hyperostosis, by contrast, causes thick, flowing areas of ossification along the anterior spine. Sacroiliitis is a key distinguishing feature. It is typical of ankylosing spondylitis, but is generally absent in both degenerative spondylosis and diffuse idiopathic skeletal hyperostosis. That is an important clue. Disc changes also help. In early ankylosing spondylitis, disc spaces are relatively preserved, whereas degenerative spondylosis causes typical degenerative disc changes. In diffuse idiopathic skeletal hyperostosis, disc height is usually maintained.
Finally, vertebral squaring favors ankylosing spondylitis, while degenerative changes suggest spondylosis, and flowing anterior ossification points toward diffuse idiopathic skeletal hyperostosis.
Laboratory investigations in ankylosing spondylitis help assess inflammation, support the diagnosis, identify other conditions, and monitor treatment safety. C-reactive protein and erythrocyte sedimentation rate are useful markers of systemic inflammation, although they may remain normal in some patients. Human leukocyte antigen B27 can support the diagnosis, but a positive result alone does not establish ankylosing spondylitis. Other tests help with the wider clinical picture. A complete blood count may show mild anemia related to chronic inflammation, while rheumatoid factor and anti-cyclic citrullinated peptide antibodies are usually negative and can help distinguish ankylosing spondylitis from rheumatoid arthritis. Safety monitoring is also essential. Renal and liver function tests provide baseline information and help monitor treatment effects, particularly with long-term anti-inflammatory drugs and disease-modifying therapies. Before biologic treatment, screening for tuberculosis and viral infections is required. Bone health matters too. Dual energy X-ray absorptiometry, or DEXA, can detect reduced bone density and help identify patients at increased risk of osteoporosis and fractures. These investigations support both diagnosis and long-term management.
Disease assessment in ankylosing spondylitis uses clinical scoring systems to measure how active the disease is and how much it affects the patient. These tools also help clinicians track physical function, spinal mobility, structural damage, and response to treatment over time. Different assessment domains capture different parts of the disease process. Disease activity reflects current inflammation, while functional scores measure disability and the effect on daily activities. Spinal mobility is assessed separately, and imaging tools evaluate structural progression or active inflammation on magnetic resonance imaging. Quality of life is also important. These measures provide a standardized way to follow individual patients and allow meaningful comparisons in clinical research.
Several scoring systems are used to assess different aspects of ankylosing spondylitis. Each tool has a specific role, ranging from measuring current disease activity to assessing function, spinal mobility, structural damage, and quality of life. The Bath Ankylosing Spondylitis Disease Activity Index measures disease activity based on the patient's symptoms, while the Ankylosing Spondylitis Disease Activity Score combines clinical symptoms with a blood marker of inflammation and is widely preferred for assessing disease activity. For physical function, the Bath Ankylosing Spondylitis Functional Index measures how the disease affects everyday activities. The Bath Ankylosing Spondylitis Metrology Index focuses on spinal mobility and helps track changes over time. Structural damage is assessed using radiographic scores. The Modified Stoke Ankylosing Spondylitis Spine Score evaluates spinal damage on plain radiographs and is commonly regarded as the standard measure for radiographic progression. Other tools assess specific areas. The Bath Ankylosing Spondylitis Radiology Index measures radiographic damage across the spine, sacroiliac joints, and hips, while the Spondyloarthritis Research Consortium of Canada score measures inflammatory lesions on magnetic resonance imaging. Finally, the Bath Ankylosing Spondylitis Global Score captures the patient's overall perception of well-being, and the Ankylosing Spondylitis Quality of Life Questionnaire measures how the disease affects daily life. Together, these tools provide a broader picture of disease burden and treatment response. The main goal of treatment in ankylosing spondylitis is to control disease activity and maintain the patient's function over time. This means reducing pain and stiffness, controlling inflammation, and preserving spinal movement and posture. Treatment should also help prevent progressive structural damage and deformity, while reducing the impact of complications outside the joints. Quality of life matters. The aim is sustained remission, or, when that is not possible, the lowest practical level of disease activity. Management must be individualized. Treatment decisions depend on disease activity and severity, but also consider comorbidities, patient preferences, and how well the patient responds to therapy. There is no single treatment plan that fits everyone. Supportive care is a central part of managing ankylosing spondylitis.
working next to medical treatment to preserve mobility and physical function. Patients should understand their condition and learn practical self-management strategies that can be continued over the long term. Regular exercise is especially important. Daily spinal mobility exercises, stretching, and postural training help maintain movement and reduce stiffness, while muscle strengthening supports function. Respiratory exercises can also help preserve chest expansion and breathing capacity. Other measures may improve overall health and independence. Occupational therapy can help patients adapt daily activities, while stopping smoking and maintaining a healthy weight may reduce additional health risks. Support matters too. Patient education, self-management programs, and support groups can help individuals manage the condition more effectively and remain engaged in their care. Non-steroidal anti-inflammatory drugs are usually the first pharmacological treatment used to control symptoms in ankylosing spondylitis. Common options include naproxen, indomethacin, and selective cyclooxygenase 2 inhibitors, such as selexicab. They work mainly by reducing inflammation, which helps relieve pain and stiffness, and can improve spinal mobility. The response should be assessed regularly and treatment adjusted according to symptom control and individual risk. Safety is important. Long-term use can affect the gastrointestinal tract and kidneys, while some patients may have increased cardiovascular risk. Continuous treatment may also slow radiographic progression in selected patients, although the evidence remains mixed, and this possible benefit should not be assumed for everyone. The choice should be individualized. Use the lowest effective dose and monitor for adverse effects, especially when treatment continues over a long period. Conventional disease-modifying anti-rheumatic drugs have a limited role in ankylosing spondylitis, particularly when the disease mainly affects the spine. Sulfasalazine may help patients who have peripheral arthritis, but it has little effect on axial symptoms. Methotrexate has no established benefit for spinal disease, although it may be considered in selected patients with peripheral joint involvement. Leflunomide has also not shown proven benefit for axial disease. The distinction is important. For patients with isolated axial ankylosing spondylitis, conventional disease-modifying anti-rheumatic drugs are therefore not routinely recommended. Their use is mainly considered when clinically significant peripheral arthritis is present. Biologic and targeted therapies are used when disease activity remains high despite standard treatment, or when conventional options are not enough. They work by blocking specific pathways that drive inflammation in ankylosing spondylitis. Tumor necrosis factor inhibitors include infliximab, adalimumab, and etanercept, while interleukin-17 inhibitors such as secukinumab and ixekizumab target another important inflammatory pathway. Janus kinase inhibition is another approach, with upadacitinib being an example of a targeted oral therapy. These treatments can make a major difference. They reduce inflammation, improve pain and physical function, and may enhance quality of life, while magnetic resonance imaging can show reduced active inflammatory lesions after effective treatment. Treatment selection should be individualized, considering disease activity, associated conditions, previous therapies, and the patient's clinical response. Difficult to manage axial spondyloarthritis refers to disease that remains problematic despite appropriate care. This may involve persistent inflammatory activity, poor response or intolerance to recommended treatments, or symptoms that continue to affect quality of life. The cause is not always ongoing inflammation. Pain may also come from mechanical problems, nerve-related pain, or established structural damage, while an incorrect diagnosis, poor treatment adherence, associated medical conditions, or psychological distress can further complicate management. A careful reassessment is essential. The diagnosis and current disease activity should be reviewed, while treatment may need to be optimized or changed when inflammation remains active. Non-inflammatory pain should be addressed separately. Rehabilitation also matters.
physiotherapy, exercise, and psychological or multidisciplinary support can improve function and help patients manage the wider effects of chronic disease. Long-term management of ankylosing spondylitis requires regular follow-up to assess symptoms, physical function, spinal mobility, and ongoing inflammation, while also checking for treatment-related toxicity and structural progression when clinically indicated. Monitoring should be consistent. Pain, stiffness, and fatigue can change over time, while C-reactive protein and erythrocyte sedimentation rate may help assess inflammatory activity, although normal results do not exclude active disease. Long-term care goes beyond controlling inflammation. Bone health should be addressed to prevent osteoporosis, while vaccination, cardiovascular risk reduction, smoking cessation, and regular exercise support overall health. Early recognition of complications is essential. Multidisciplinary follow-up may be needed because ankylosing spondylitis can affect several organ systems and may require coordinated care from different specialists. Several clinical tools help assess different aspects of ankylosing spondylitis. Each score answers a different question, so they are used together rather than as interchangeable measures. The Bath Ankylosing Spondylitis Disease Activity Index, or BASDI, captures disease activity from the patient's perspective. It is scored from 0 to 10, with a score of 4 or more generally suggesting high disease activity. Ankylosing Spondylitis Disease Activity Score, or ASDAS, combines clinical symptoms with an inflammatory marker such as C-reactive protein or erythrocyte sedimentation rate. Lower scores indicate inactive or low disease activity, while higher scores reflect increasingly active disease. Function is assessed with the Bath Ankylosing Spondylitis Functional Index, or BASFI, which also ranges from 0 to 10, with higher scores indicating greater difficulty with daily activities. The Bath Ankylosing Spondylitis Metrology Index, or BASME, focuses on spinal mobility, where higher scores indicate greater restriction of movement. Together, these tools provide a broader assessment of disease activity, functional impact, and spinal limitation. That is the key point. Managing ankylosing spondylitis often requires a multidisciplinary team because the disease can affect the spine, joints, eyes, skin, and other organs. The rheumatologist usually coordinates medical treatment, while a spine surgeon or neurosurgeon may become involved when severe structural disease or neurological complications require surgical assessment. Physiotherapists and rehabilitation specialists help maintain mobility, posture, and physical function, while pain specialists can address persistent pain that does not respond fully to anti-inflammatory treatment. Other specialists, such as ophthalmologists and gastroenterologists, contribute when extra-articular manifestations occur. The specialist nurse and occupational therapist also have important roles in education, daily function, and long-term self-management. Patient education matters greatly. Shared decision-making is central to care, helping patients understand treatment choices and take an active role in managing their disease over time. Surgery is considered when ankylosing spondylitis causes advanced structural problems that significantly affect function or threaten neurological safety. This may include a fixed kyphotic deformity, progressive spinal deformity, or an unstable spinal fracture, particularly when neural compression or neurological deficits are present. The surgical procedure depends on the specific problem. Corrective spinal osteotomy can restore spinal alignment in severe fixed deformity, while decompression may relieve pressure on neural structures. Instrumented fusion provides stability, and fracture stabilization is used when the rigid spine has sustained an unstable fracture. These are major procedures. Careful planning is essential. The surgical strategy for correcting spinal deformity in ankylosing spondylitis depends on several patient-specific factors. The severity and flexibility of the deformity are important, while bone quality and neurological status also influence the safety and choice of procedure. Medical fitness and any previous spinal surgery must also be considered, because these factors can affect both surgical risk and the available operative options. Careful planning is essential.
Depending on the deformity and the patient's condition, correction may be performed through a posterior-only approach or through combined anterior and posterior surgery. The procedure can also be completed in a single stage or divided into separate operations when staged correction offers greater safety. The goal is effective correction with minimal risk. Corrective surgery may be considered when progressive kyphosis becomes severe enough to interfere with daily function and overall quality of life. Patients may develop difficulty maintaining a forward gaze, problems with walking or standing balance, or respiratory compromise as the deformity progresses. Chronic pain and increasing functional disability are also important indications, particularly when conservative treatment no longer provides adequate relief. The deformity can become highly disabling. The main surgical goals are to restore sagittal balance and improve the patient's ability to look forward and maintain an upright posture. Surgery also aims to relieve pain and improve mobility, function, and overall quality of life, while achieving correction as safely as possible. Corrective osteotomies are surgical procedures used to restore spinal alignment when a fixed deformity, such as severe kyphosis, cannot be corrected through simpler methods. The two major techniques are the opening wedge osteotomy and the closing wedge osteotomy, which differ mainly in how the spinal segment is opened or closed to achieve correction. An opening wedge osteotomy creates a controlled opening within the vertebral column, allowing correction through anterior column lengthening. A closing wedge osteotomy removes a wedge of bone and closes the gap to restore alignment, usually by shortening the posterior elements. Both techniques can provide meaningful correction. The choice depends on the deformity, bone quality, spinal anatomy, and surgical goals. An opening wedge osteotomy corrects spinal deformity by creating a controlled opening through the posterior part of the spine. The posterior elements are removed, and the correction occurs around a hinge located toward the back, which allows the anterior column to open and lengthen. This technique can achieve substantial angular correction and may be useful in selected patients with a flexible deformity. However, the anterior column must be distracted, which can place greater stress on the implants, and because the anterior longitudinal ligament is disrupted, carries a risk of vascular injury. It provides powerful correction. Careful planning is essential. A closing wedge osteotomy corrects a fixed spinal deformity by removing a wedge of bone from the posterior part of the vertebra. The vertebral body is carefully decancellated, allowing the anterior cortex to act as a hinge while the posterior column is shortened and closed. This creates direct bone-to-bone contact, which provides immediate stability and supports reliable fusion while reducing stress on the implants. It is a powerful and stable technique. The closing wedge osteotomy is commonly performed around the thoracolumbar junction, where substantial correction can be achieved through controlled closure of the osteotomy. Corrective spinal osteotomy is a major procedure, and complications can affect several systems. Neurological injury may involve the spinal cord or nerve roots, while a dural tear can lead to cerebral spinal fluid leakage and related problems. Vascular complications are less common but potentially severe, particularly when major blood vessels or the aorta are injured during correction. These risks require careful preoperative imaging and surgical planning. Mechanical complications can develop when the reconstructed spine fails to maintain stability. Implant failure, pseudoarthrosis, loss of correction, or instability of the anterior column may compromise the surgical result. Blood loss can be substantial. Technical complications may also occur during the procedure, especially in patients with severe deformity, poor bone quality, or previous spinal surgery. Careful planning and meticulous technique are essential to reduce these risks. Reducing complications from corrective spinal surgery begins before the operation. The patient's nutritional status, heart and lung function, and bone strength should be assessed and optimized, while detailed imaging helps the surgical team understand the deformity and plan the procedure safely. Intraoperative measures focus on protecting neural structures and maintaining spinal stability. Neuromonitoring can help detect changes in neurological function during surgery.
while controlled osteotomy closure and rigid fixation improve stability and reduce the risk of mechanical failure. The postoperative period is equally important. Early mobilization, adequate nutritional support, and structured rehabilitation help recovery, while serial imaging allows the team to identify loss of correction or other complications early. Good planning reduces risk. Care continues after surgery.
Spinal fractures are an important complication of ankylosing spondylitis. As the spine becomes fused and loses its normal flexibility, it behaves more like a long, rigid bone, so even a minor fall can produce a serious fracture. Osteoporosis further weakens the vertebrae, while the long lever arm effect of the rigid spine increases the forces transmitted across the injured segment. Kyphotic deformity and ossified spinal ligaments can add to this mechanical stress, and reduced mobility may also increase the risk of falls. These fractures are often highly unstable. Even low-energy trauma can cause a fracture involving all three spinal columns, with the cervical spine commonly affected, and the overall fracture risk estimated at about 3 to 7 times higher than in the general population. Minor trauma can have major consequences. Prompt imaging and careful spinal protection are essential when a fracture is suspected.
Conservative treatment means managing the fracture without an operation, usually with careful observation and appropriate support. It may be considered when the fracture is stable and the patient has no neurological deficit, or when surgery carries an unacceptably high risk. This approach can also be suitable for carefully selected elderly or frail patients. Patient selection matters greatly. The main concern is that the fracture may not remain stable during healing. A patient can develop worsened alignment or instability over time, and healing may fail to occur properly. In some cases, neurological problems can appear later, even when the initial examination was normal. These risks mean that close clinical and imaging follow-up is essential, especially when treatment is non-operative. Most unstable spinal fractures, however, require surgical stabilization to restore alignment and prevent further damage. Surgery aims to restore stability and protect the spinal cord and nerves. When neural structures are compressed, decompression may be required, while stable fixation promotes fracture healing and allows earlier mobilization, which can reduce overall complications and mortality. Surgical treatment is mainly indicated for unstable three-column fractures or when neurological function is threatened. It is also considered when there is significant cord compression, an epidural hematoma, progressive displacement, or a deformity that cannot be corrected without surgery. Failure of conservative treatment is another important indication. Early stabilization matters. It helps prevent further displacement and neurological deterioration. The posterior-only approach is commonly preferred for most unstable fractures because it allows strong fixation across multiple spinal levels above and below the injury, which is especially important in an ankylosed and osteoporotic spine. Anterior-only fixation has a more limited role. It may be suitable when the injury is confined mainly to the anterior column, but it often provides inadequate stability in an ankylosed spine with poor bone quality. For severe instability or major loss of anterior column support, combined anterior and posterior fixation may provide stronger reconstruction. This approach can also be considered when previous fixation has failed. Minimally invasive fixation may be useful in selected elderly or medically frail patients who may not tolerate extensive surgery. However, long segment fixation is usually necessary because osteoporosis weakens screw purchase and the rigid spine creates long lever arms that increase mechanical stress. The fixation must match the biomechanics. Stability is the priority. Cauda equina syndrome is a rare, late complication of long-standing ankylosing spondylitis, usually developing after many years of disease. Chronic inflammation can cause arachnoiditis and fibrosis around the meninges, leading to nerve root adhesions and, in some patients, dorsal arachnoid diverticula. The clinical picture reflects damage to the lower spinal nerve roots. Patients may develop altered sensation around the saddle region, weakness or sensory loss in the legs, and bladder or bowel dysfunction.
Sexual dysfunction and persistent lumbosacral or radicular pain may also occur. Magnetic resonance imaging is the imaging method of choice because it can demonstrate changes around the nerve roots and associated structural abnormalities. Management is mainly supportive. Neurological care, rehabilitation, and careful bladder and bowel management are important. Surgery has a limited role and is generally considered only when imaging identifies another treatable compressive lesion. Early recognition remains important. The neurological deficits can be severe and persistent. Osteoporosis is an important challenge when stabilizing the ankylosed spine. Poor bone quality reduces the strength of screw fixation and increases the risk of screw loosening and implant failure. Strong fixation is essential. Surgeons may use longer fixation constructs with multiple points of anchorage to spread mechanical forces across a wider area, while cement augmentation can improve screw purchase in selected patients. Osteoporosis should also be treated actively before and after surgery when possible. Better bone quality supports fixation and may improve long-term stability. The goal is durable stability. Good bone matters. Neurological complications in ankylosing spondylitis can be serious, particularly because the rigid spine is vulnerable to injury, even after relatively minor trauma. Fractures may damage the spinal cord, while cervical myelopathy can develop from chronic compression. Other complications include nerve root dysfunction, epidural hematoma, and rarely peripheral nerve involvement. Cauda equina syndrome is another important late complication, while instability at the upper cervical spine can also threaten neurological function. These problems require careful assessment. The consequences may be severe. Certain symptoms should raise immediate concern. New spinal pain after minor trauma, progressive limb weakness, or a change in gait may indicate an unstable fracture or neurological injury. Sensory loss, saddle anesthesia, or new bladder and bowel dysfunction are particularly concerning, while upper motor neuron signs may suggest spinal cord involvement. Any new neurological symptom in a patient with ankylosing spondylitis should be treated as a potential spinal emergency until serious structural injury has been excluded. Prompt imaging and specialist assessment are essential. Do not underestimate minor trauma. The ankylosed spine can fracture. When a neurological complication is suspected, imaging should be performed promptly. A whole spine computed tomography scan is important when a fracture is possible, because injuries may occur at more than one spinal level. Magnetic resonance imaging is used to assess the spinal cord, nerve roots, epidural space, and other soft tissues. Electromyography and nerve conduction studies may help when a peripheral nerve disorder is suspected. Treatment depends on the underlying problem. Unstable fractures require urgent stabilization, while significant neural compression may require decompression. An epidural hematoma also needs prompt management when it threatens neurological function. Rehabilitation and multidisciplinary supportive care remain important throughout recovery. Timing matters greatly. Early diagnosis and timely treatment can prevent permanent neurological deficits. Prognosis in ankylosing spondylitis varies between patients. Some features are linked with a higher risk of progressive disease and long-term disability, including early disease onset and hip involvement. Smoking and physically demanding work may also contribute to poorer outcomes, while multiple comorbidities and established structural damage can further increase the burden of disease. Several factors are associated with better long-term outcomes. Early diagnosis allows treatment to begin sooner, while effective control of disease activity may limit ongoing inflammation and functional decline. Regular exercise and rehabilitation help maintain mobility and physical function, and preventing complications remains an important part of long-term care. Early action can change the disease course. Good management matters. In conclusion, managing ankylosing spondylitis requires an individualized approach, with care often involving several healthcare professionals. The goal is to control inflammation, preserve spinal mobility, and prevent long-term disability while addressing each patient's specific needs. Initial treatment focuses on patient education, regular exercise, physiotherapy, and nonsteroidal anti-inflammatory drugs, which remain the foundation of early management. Conventional disease-modifying anti-rheumatic drugs have a limited role, particularly for spinal disease. However, tumor necrosis factor inhibitors and newer biologic therapies have greatly expanded effective treatment options for patients with active disease. Surgery is generally reserved for advanced structural problems or severe deformity, where appropriate intervention can restore function and improve quality of life. Early diagnosis and timely treatment are important. They can change the long-term outcome significantly. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Like, comment, share, and subscribe to stay connected with our latest educational content. Thanks for watching. Stay tuned for more.